Hello everyone, this is Dr. Singaram, your Pediatrics faculty. Welcome to this session on recall question discussion in Pediatrics asked in this INI-CET November 2025 session. Before I start the discussion, these questions are based on the memory recall of students who have attended the actual exam. So there can be some variations in the wordings in the question, and depending on that, the final answer can also change. But depending on the question which I have got from the students, we have put it together and we'll take a discussion based on that. Second thing is about the nature of questions and the number of questions asked in this November session of INI-CET. It was a standard paper having 12 questions from Pediatrics, and as usual, it was expected as integrated question where you have to apply the other subject knowledge to come to a final answer. And also some of the questions were based on the guidelines for management of conditions like diabetic ketoacidosis, dengue fever, and few conditions were also asked in this exam. And also what I could observe from the recent INI-CET pattern is they tend to ask question on different aspects of repeatedly asked topics, like for example short stature, guidelines on DKA management, right? Like those type of questions are often being repeated in the exams, and even in this exam also there were topics, questions based on those frequently asked topics, right? So it is very important that when you are preparing for the upcoming INI-CET exams, please make sure you make a list of all the topics which are asked in the last 3 to 4 years of INI-CET across the 2 sessions, and do a complete reading of the entire topic, right? That will help you to solve the future questions on the same topics, right? So with that introduction, let us get started with the questions asked in this session. The first question is developmental milestone. Always an expected question, right? And this time also it came in the exam. It is which of these milestones is correctly matched with the corresponding age? Stacking 2 cubes in a tower 2 years, mature pincer grasp at 9 months, transferring the object from one hand to another hand by 6 months, reaching out to the object with one hand by the age of 8 months. We have to find which is the correctly matched statement. For that, let us take the discussion in terms of milestones one after another. First milestone given was stacking 2 cubes in a tower by the age of 2 years. This is absolutely wrong, because stacking 2 cubes in a tower is usually by the age of 15 months of age, right? Not by 2 years. Next one, mature pincer grasp 9 months is again wrong, because mature pincer grasp is attained by the age of 12 months. So that is also wrong. Third one, transferring the object from one hand to another hand, that is definitely attained by the age of 6 months, and that is a correct statement. Then reaches out to the objects with a single hand, that is unidextrous grasping. Unidextrous grasping. Is it attained at 8 months? Again, it is wrong, because it is attained by the age of 6 months only. So out of the 4 statements given in the question, only the third statement is correct. So obviously option C will be the answer for this particular question. It is just based on your recall of the milestones at what age they are attained, right? It's a very standard question. So when you are going to appear for the future exams also, make sure you go through all the milestones very correctly. Okay, right. Moving on to the next question. A term neonate delivered by cesarean section develops tachypnea and mild respiratory distress shortly after birth. Chest X-ray shows prominent vascular markings with fluid in the interlobar fissure and a normal cardiac shadow. The symptoms resolve completely within 48 hours. What is the likely diagnosis? RDS, meconium aspiration syndrome, pneumonia, transient tachypnea of newborn. See here, there are few keywords for you to remember. One is a term baby delivered by cesarean section and having respiratory distress. That itself should sound some condition in your mind. Okay. Second is prominent vascular markings with the fluid in the interlobar fissure. There is evidence of fluid inside the lungs. That is the second important clue. Third important clue, symptoms resolve completely within 48 hours, meaning it's a transient condition only. So all these 3 clues are pointing to only one diagnosis out of the 4 options. What is that? Yes, it's a clear condition of TTNB, or what is called transient tachypnea of newborn, right? This is a topic which appeared in this May 2025 session also. As an image-based question, they framed that particular question. This time it was a very straightforward clinical scenario with some X-ray finding given in wording section, right? Just some quick points to know about transient tachypnea newborn. First and foremost thing, it's common in term or late preterm babies who are delivered by lower segment cesarean section. That is number 1. Number 2, the reason for respiratory distress in this condition is due to retained lung fluids. Okay, retained lung fluids. It's basically the lung fluids are cleared later compared to a normal situation, right? Delayed clearance of lung fluid or retained lung fluid is the reason for this respiratory distress in this condition, and this can be made out with the help of the X-ray. And this was the X-ray which was asked in the last May exam, and that X-ray was showing the evidence of fluid in the form of all these perihilar bronchovascular markings which are filled with the fluid inside them. And this type of appearance, perihilar fluid accumulation, is what we call sunburst appearance. Okay, right? Very typical X-ray appearance in this condition. Second important X-ray appearance is between the upper lobe. Think about this, upper lobe and the middle lobe of the lung. There is a interlobar fissure or the horizontal fissure that can also be filled with the fluid. Fluid in the interlobar fissure is the next important finding. Fluid in the interlobar fissure. So basically, you need to look for evidence of fluid in the X-ray to support your diagnosis of TTNB. Third important is it's a transient condition. And it is usually self-limiting within few hours, maximum up to 48 to 72 hours. It can be present after birth. And usually the treatment, most of the time the treatment required is oxygen supplementation, and that too minimal oxygen requirements with FiO2 of less than 40% will be required. Okay, so it's a harmless condition, right? That is why the name itself is called transient tachypnea of newborn. And based on all this discussion, the clear answer for our question is option D, which is TTNB or transient tachypnea of newborn. Okay, right. Moving on to the third question. Which of the following is correct regarding acute rheumatic fever? This time, there were 2 questions about acute rheumatic fever. And if you have seen the previous year papers, this acute rheumatic fever is often repeatedly asked topic in the exams. Okay. Acute cases can present with aortic valve rupture, happens 2 weeks after group B streptococcus infection. Myocarditis occurs but not endocarditis. Ash of bodies are seen. Let us see the options individually. Okay. The first option, acute cases can present with aortic valve rupture. This is a wrong statement because in acute rheumatic fever, it is not commonly the aortic valve which is affected. It is a mitral valve which is usually affected in the form of mitral regurgitation, because there can be rupture of papillary muscles which can predispose to mitral valve regurgitation. So aortic valve rupture is not the correct statement, so that is wrong. The second option, it happens 2 weeks after group B streptococcus infection. Remember, acute rheumatic fever is post-streptococcal only. It can happen 2 weeks after the infection, but not group B. It is group A beta hemolytic streptococci. Very important wordings, right? It is group A beta hemolytic streptococci and not group B, right? So that is something which is wrong. Myocarditis occurs but not endocarditis. This is again a wrong statement because the rheumatic fever association with carditis is pancarditis, where all layers of the heart is affected. What are they? Myocarditis, endocarditis and pericarditis, right? All layers of the heart are affected. So not endocarditis is a wrong statement. Then look at the last option. Ash of bodies are seen. That's a correct statement. In fact, that is supposed to be pathologically the hallmark finding of rheumatic fever when you do the biopsy, right? This is a picture of the ash of body. Ash of body is basically an area of fibrinoid necrosis. Very important. Fibrinoid necrosis occurring as a part of granulomatous inflammation in this particular condition. Okay. And one characteristic feature is that the fibrinoid necrosis is surrounded by a lot of macrophages, inflammatory macrophages. And one special type of macrophage is like this. What is that called? It's called Anishkov cells. Anishkov cells. And these Anishkov cells are also called as the caterpillar cells. Why? Because if you look at the nucleus, you can see this area, right? The nucleus area is an elongated nucleus with a wavy, ribbon-like appearance of the chromatin, or wavy ribbon-like chromatin pattern resembling like that of a caterpillar. So that is why it's also called caterpillar cells. And this is the description, complete description of the ash of body. So the clear answer for our particular question is option D. Ash of bodies are seen is a correct statement regarding acute rheumatic fever. So this is one question which you have to integrate your pathology knowledge and apply for this particular question. The second question about acute rheumatic fever is Jones criteria. We all know that it's a criteria used for diagnosis of acute rheumatic fever, has several major and minor criteria. Which of the following are included in the major or minor criteria of Jones criteria? Okay, right? It's a very straightforward question. Once you know the criteria, you can easily pick up the answer. Carditis. Just now I was telling you pancarditis is a feature. It is included under Jones criteria also. So that is correct. Erythema nodosum? No. There is a erythema noted in acute rheumatic fever, but it is erythema more in the margins with a center clear area. What do you call that? Yes, erythema marginatum. It is called erythema marginatum. So that erythema nodosum is a wrong one. It's not related to Jones criteria. Polyarthralgia is a fever. You can get polyarthralgia, you can get monoarthralgia also in case of acute rheumatic fever. That is also included under Jones criteria. So that is correct. Short PR interval is wrong because in the criteria, the minor criteria, what is there? There is a prolonged PR interval and not a short PR interval. Okay, right? Syndrome's chorea is a neurological manifestation included under the major criteria of Jones criteria. So that is also there. So if you see 1, 3 and 5 are correct regarding the Jones criteria and acute rheumatic fever. So which option fits into that? It is option C, which will be the final answer for this particular question. Purely a question based on recall of Jones criteria in acute rheumatic fever. Moving on to our next question. All of the following statements regarding Hirschsprung disease are true except. We all know about this famous condition of Hirschsprung disease, which is aganglionosis, right? Okay, congenital aganglionosis. Let's elaborately discuss little later. First, look at the option and try to form an answer for yourself and then check with the final answer. Failure of migration of ganglion cells. Option B, colonic segment proximal to the affected area is constricted. Failure of passage of meconium in the postnatal period and loss of coordinated peristalsis, which is false statement. That means true except. Okay, let's see some quick points about Hirschsprung disease. Remember, it's a condition of absent ganglions in the intestine. That too, large intestine, a part of the colon is getting affected. Okay. And this is basically a neuronal migration problem where there is a failure of neuronal migration from the neural crust to the intestine. For that reason only, it's called neuronal migration disorder. And what is the problem due to this? There will be absence of ganglions, aganglionosis. That's why this condition is also called congenital aganglionosis. And because of aganglionosis, what happens? The peristaltic activity is getting affected. It affects the peristalsis, due to which what happens is the affected part of the intestine, that is a large intestine talking about, or a part of colon, is always constricted or narrow segment of colon is noted. Commonly like rectum or the rectosigmoid areas are getting affected and the affected area is narrow. So think about rectum as an example I'm taking is becoming narrow. And because of this narrowing, the meconium or the stools cannot pass through the narrow rectum. So what will happen? The proximal areas, that is above the obstruction, all the parts of that intestine, they will become dilated. Proximal areas are the dilated. Okay, proximal areas are the unaffected areas. Very important. Unaffected areas, that is those which are proximal to the obstruction, are dilated because they are filled with the meconium or the stools inside. Whereas the affected area, due to absent ganglion, it becomes narrow. This should be very clear. And you can very clearly understand that through the narrow part, affected part, the meconium or the stools cannot pass through, thereby resulting in failure of passage of meconium, and all the meconium stays inside the unaffected parts of the intestine, resulting in abdominal distension also, right? That is what we study as the characteristic feature of this particular condition. So if you go back to the options, failure of migration of ganglion cells is correct. Colonic segment proximal to the affected area is constricted. What did I tell you? Colonic segment proximal to the affected area is the normal area. Unaffected area. What happens to the normal area? It is not constricted. It is dilated. It is dilated because it's loaded with the meconium inside, right? So it's going to be dilated. So that is a wrong statement and be the answer for the question. Then failure of passage of meconium in the postnatal period, that is correct. And loss of coordinated peristalsis is also correct, which is explained by the pathophysiology of this condition. So the very clear answer for our question is option B is the false statement and will be the final answer for this particular question on Hirschsprung disease. Moving on to our next question. Again, a question which is integrated with pathology. A 5-year-old child with 4+ proteinuria, that is on dipstick 4+ proteinuria, which is falling under the criteria for massive proteinuria, is unresponsive to corticosteroid therapy. See, what is a condition which we get in a child with massive proteinuria? It is nephrotic syndrome. So basically the question is about nephrotic syndrome. Unresponsive to corticosteroid therapy means it is steroid resistant nephrotic syndrome. That is what basically this question is asking about. Steroid resistant nephrotic syndrome. There is no hematuria or hypertension. Renal biopsy, because remember, every child with a steroid resistant nephrotic syndrome, you have to do renal biopsy, which is done in this case also. Renal biopsy shows segmental sclerosis and hyalinosis, predominantly involving juxtamedullary glomeruli. What is the most likely diagnosis? See, if you look at the options, what is the commonest cause of nephrotic syndrome in a child? It is minimal change disease. But minimal change disease, it's a steroid responsive condition. It's a steroid responsive condition, correct? So that cannot be the answer for this question. Straight away, we can rule it out. Okay, right. See, membranous nephropathy is not at all common in children. It's more common in adults. Not only that, membranous nephropathy can have a presentation itself with hematuria and hypertension. More of a nephritic presentation can be there. So that is ruled out, right? Okay. Then look at the remaining two options. Your entire answer is going to be based on the biopsy only. Renal biopsy shows sclerosis and hyalinosis of the glomeruli. Which condition fits into that? It is obviously focal segmental glomerulosclerosis, because if it were an IgA nephropathy, they should have definitely mentioned mesangial deposits of IgA is noted. Mesangial deposits of IgA should be noted. Not only that, the characteristic presentation of IgA nephropathy is with recurrent hematuria. And clearly in the question it is mentioned there is no hematuria or hypertension. So that is definitely ruled out. So clear answer for this question is option B, FSGS only. Just a quick go through of some facts in FSGS. Remember, FSGS is the most common cause of steroid resistant nephrotic syndrome. Most common cause of steroid resistant nephrotic syndrome is FSGS. That is number one point. And the hallmark finding in the biopsy is always segmental sclerosis plus hyalinosis. That's why the name itself is called focal segmental glomerulosclerosis, right? Very straightforward. And another important clue given in the question was something related to biopsy again, which is the early finding of this condition. What is that? It is juxtamedullary glomeruli which are getting affected in this condition. If I take you back to that question, it's clearly mentioned in the question that there is an involvement of juxtamedullary glomeruli. So all this clearly fits into a possibility of FSGS, and also often no hematuria or hypertension initially, which was also given in the question that their child is not having any hematuria or hypertension. So for all these reasons, the clear answer for our question is going to be B, which is FSGS or focal segmental glomerulosclerosis. Okay, moving on to the next question. This is also a question which is nowadays I see many a times in your INI-CET exams. A question related to short stature. See this. A 7-year-old child present with short stature. Height is -5 SD, which is very well below -2 standard deviation or the cutoff for short stature. So definitely short stature is documented in this child. The child is eating well and gaining weight. On examination, upper segment to lower segment ratio is 1.4:1 and systemic examinations are within normal. What is the most likely diagnosis? So your entire answer in this particular question is going to be based on upper segment, lower segment ratio. So we'll just do a quick recap of this US-LS ratio and then we'll come back to this question. Okay. See, the normal values. First of all, you need to remember the normal values. At the time of birth, it is 1.7:1. Upper segment is more compared to lower segment. So that's why the ratio is 1.7:1. But after birth, the lower segment or the legs keep on increasing in size. So that is why the ratio keeps on decreasing after birth. What is the normal value at the age of 3 years? It is 1.3:1. 6 years, it is 1.1:1. 10 years, it is 1:1. And by more than 10 years, it is 0.9:1. Okay, so you can see as the age increases, the upper segment, lower segment ratio decreases because lower segment represented by the limbs grows more compared to the upper segment. That is our basic understanding. Okay. Now, how does this ratio help in evaluation of a child with short stature? It is simple. Based on the ratio in a short stature child, we can divide it into two categories. One is called proportionate short stature. Proportionate short stature, when the ratio is normal for the age, we can call it proportionate short stature. And the next obvious one, where the ratio is abnormal ratio, you will call it as disproportionate short stature. Very easy one, disproportionate short stature. Right. And this disproportionate short stature could either be a problem in the upper segment or it could be a problem in lower segment. So we can divide it like this: short upper segment short stature or short lower segment short stature. Like that we can remember. Okay, right? See, basic understanding, when the upper segment is short, what will happen to the ratio? The ratio also will be less compared to normal. That is what I want you to remember. But if the lower segment is short, what will happen to the ratio? Ratio will be more or increased ratio compared to normal. Very simple. This is our basic understanding of how the ratio helps in the classification of short stature. Now let's come back to the question. In our question, it's a 7-year-old child with the ratio of 1.4:1. Quickly tell me, what would be the normal ratio for a 7-year-old child? It is somewhere equal or around the 6 years range. What is the 6 years range I told you? 1.1:1. Okay. So compared to 1.1:1, this 1.4:1 is abnormal ratio or it is a disproportionate short stature. I think that part is clear. Disproportionate short stature. Fine. And also compared to this normal ratio, the child's ratio is showing an increased ratio, right? It is increased. And if I go back to that previous one, what does this increased ratio tell you? It's a short lower segment short stature, correct? It's a short LS or a short lower segment short stature because the ratio is increased in this particular child. Okay. And lower segment is represented by the lower limbs. So some sort of problem related to the limbs only should have caused the short stature in this particular child. So now let us see the options. Look at the options. Okay. Spondyloepiphyseal dysplasia, achondroplasia, growth hormone deficiency, and severe malnutrition. Okay. First of all, if it is acute malnutrition, height is not affected at all. Okay, right? So it won't be even a short stature. So that is directly ruled out. Look at the third option, growth hormone deficiency. Growth hormone deficiency is characterized by proportionate short stature. Very important point. It's characterized by proportionate short stature. So that cannot be the answer for this question. So that is also ruled out because we have a disproportionate short stature in our question characterized by short limbs or the lower segment. So now tell me, out of these two, spondyloepiphyseal dysplasia and achondroplasia, which is the answer? Answer is achondroplasia because that is only characterized by short lower segment of the limbs. Whereas if it is spondyloepiphyseal dysplasia, spondylo means something related to the vertebra. Vertebra related problems always will cause short upper segment short stature. Short upper segment short stature. But in our question, it is short lower segment short stature only. So that is why the answer, final answer for this particular question is option B, which is achondroplasia. Moving on to our next question. It's a straightforward one. A 1-month-old child presents with recurrent pneumonia and no cyanosis. On examination, a continuous murmur is heard below the left clavicle and a bounding pulse is present. What is the most likely diagnosis, right? Remember, all the options ASD, VSD, PDA and coarctation of aorta are all congenital heart defects, right? And no cyanosis means it's a acyanotic congenital heart defect, right? Okay. Now, the clue for this question is straightforward coming from the continuous murmur below the left clavicle. That means infraclavicular area, and only one diagnosis there. What is that? It is patent ductus arteriosus. We know the classical murmur. What is that? A loud murmur, also called the machine-like murmur, and also it is a continuous murmur. So it's a very straightforward answer for this particular question. It is PDA only. Now, why there should be a recurrent pneumonia? Why? Because PDA is classified under left to right shunt, which results in pulmonary congestion, and because of the pulmonary congestion, it predisposes to recurrent pneumonia. So that is the reason for recurrent pneumonia. And also, what is the reason for bounding pulse? During diastole, what happens is there is a runoff of blood from the aorta into the pulmonary artery, and this happens during diastole. And because of that, the diastolic pressure will decrease. creating an increased difference between the systolic and the diastolic blood pressure. So the pulse pressure itself is going to increase. That is what you are able to feel as a bounding pulse in this particular condition. So all this put together is very clearly associated with patent ductus arteriosus, which will be the answer for this particular question. Moving on to the next question, which you have to answer based on analyzing all the features given in the question. It's a case scenario question, and it's a next best step in management type of question. Okay, a 3-year-old child presents with a cough, wheeze and recurrent infection for which he has been taking oral medications. He now presents with excessive weight gain, a round face, hirschsprung, and hair growth in the forehead. Developmental milestones were normal. Child's BMI is more than +2 standard deviation, but height for age is below -2 standard deviation. What is the next best step in management? Is it checking for congenital hypothyroidism with T3, T4, TSH, or checking for early morning cortisol and exogenous cortisol administration? This is history of exogenous cortisol administration, that option. Or advise exercise and dietary changes for this child. Evaluate for genetic causes of obesity, right? Let us take it in a stepwise manner. First is about the approach to the question. What is written? This child, young child, is having excessive weight gain, round face or a moon-like face, as well as abnormal hair distribution or hirschsprung is noted. Along with that, there is also growth failure which is noted. Why? Because in the values, do you remember, the weight was high, more than +2 standard deviation, falls under the overweight range, okay? And also short, height was below -2 standard deviation, right? Short stature range. That is what is growth failure I have written. And also there is a history of long-term oral medication. What this could be? See, possibly all these are Cushingoid features. Are you able to follow this? All these are Cushingoid features. That overweight, obesity, along with that moon face, hirschsprung, okay, and also growth retardation falls under the Cushingoid features along with the Cushingoid facies also. And what it could be, this long-term oral medication could have been possibly steroids. For a long-standing problem in this particular child, maybe we can correlate with that history of wheezing, and for that wheezing, maybe the child could have been prescribed steroids for a long period of time. So it's more of a iatrogenic steroid usage or exogenous type of Cushing syndrome we need to keep in mind. Exogenous type of Cushing syndrome we need to keep in mind. So ideally, what should be my next step? I have to document excess cortisol level by checking for this morning cortisol. I can do that. And one more is I can ask the history or review the history to know whether it was a steroid exposure in that particular child. So based on all this, what is the best answer for our question? It is option B, which is checking for early morning serum cortisol to document high cortisol level. And also the history of exogenous cortisol administration should be documented so that we can prove that it's a case of iatrogenic or exogenous Cushing syndrome. Okay, it's not hypothyroidism because no way it is suggesting the possibility of hypothyroidism. Next is advise exercise and dietary changes. If the child was only having obesity, we can say that. But there are features of Cushing syndrome. We can't just only do advise dietary and exercise. So that is wrong. Then evaluate for genetic cause of obesity, meaning some genetic disorders. See, if it was a genetic disorders, I don't expect the developmental milestones to be normal in this child, right? So very simple, right? There can be developmental delay. They would have given the history like intellectual disability can be there. All those things were not given in the question. So very clearly it is not evaluation for genetic cause, right? That is also wrong. So clear option for this question is option B only because we are suspecting Cushing syndrome in this particular child. Moving on to the next question. A 3-month-old infant presents with a prolonged jaundice, dark urine and pale stools. The child is exclusively breastfed and otherwise well. HIDA scan is non-excretory. What is the next best step in management? Okay, let us try to put it together. Jaundice in a small baby. Along with that, dark urine and pale stools. Dark urine and pale stools very clearly tells you what type of bilirubin is increased. It is increased conjugated bilirubin. Don't forget that. It is an increased conjugated bilirubin. Or another word, it suggests cholestasis. It suggests cholestasis. Okay, it is suggesting cholestasis. Now, as a part of evaluation of cholestasis only, what test is being done? HIDA scan is being done. HIDA scan basically test for the elimination or excretion of the tracer from the liver into the intestine through the bile duct. And it is very clearly saying it is non-excretory, means it suggests some sort of obstruction. And tell me, in a small baby like this, what is the most common cause of obstruction causing cholestasis? It is EHBA. What is EHBA? It is extrahepatic biliary atresia. It is extrahepatic biliary atresia, right? That is our clinical possibility in this particular child. Now let us see what should be the next best step in management. Let me take the options one after another. The first option was rule out galactosemia using enzyme assay. Is it correct? No, it is wrong. It is not even galactosemia in our question. So that is anyway ruled out. Or if it is galactosemia, they should have given some other clues like hepatomegaly, cataract, the oil drop cataract, like that should have been given as a clue. It's not given, so that is anyway out. Option B, the child has breast milk jaundice and start formula feeding after 3 weeks. It's outright wrong option. Why? Breast milk jaundice, first of all, will be characterized by increased unconjugated bilirubin and not conjugated bilirubin. So that is automatically out in this question. Okay, fine. Then immediate liver biopsy to confirm diagnosis. That is our next best step. Okay, because once the HIDA scan is telling you suspicion of extrahepatic biliary atresia, we need to do liver biopsy only, which will confirm our diagnosis. That is very true. And what are you going to see in the liver biopsy? Extensive fibrosis will be noted. And also you will get features of periductular as well as neoductular proliferation. Neoductular proliferation, right? So this is how we will establish our diagnosis in this particular case. In fact, one of your previous questions was based on the liver biopsy finding itself, and they asked you what is the diagnosis also. So that way also question can come. So liver biopsy is the next best test to confirm the diagnosis, and these are the findings you will get in extrahepatic biliary atresia. Look at the last option. What is the last option? Perform a hepatic ultrasound to look for causes like biliary atresia, right? See, ultrasound is actually initial test, which should have been done even before the HIDA scan. Okay, right? Here already HIDA scan is done. Then we don't need to go back again and do the ultrasound, right? So that is also a wrong statement, because that is the initial testing only. We have already crossed that stage and we have done the HIDA scan. So the next thing after HIDA scan is always biopsy. So option C will be the best answer to choose for this particular question. Moving on to our next question. A 10-year-old child presented with abdominal pain and vomiting. Lab values are given below. What is the next best step in management? These are the lab values, where the blood sugar is 415. It is very, very high. pH is 7, which is suggestive acidosis. Bicarbonate is also low, which is only 4, which is also suggesting the metabolic acidosis. Sodium is 145, potassium is normal 4.8 milliequivalents per liter. Now, with this combination, acidosis and high blood sugar value in a child with abdominal pain and vomiting, which condition should be thought about? Yes, it is DKA. What is that? Diabetic ketoacidosis. This is something important, right? Diabetic ketoacidosis, and this is a question based on that only. See, a very basic biochemical definition of diabetic ketoacidosis is suggested by 3 things, out of which 2 is already given in the question. One is blood sugars. Okay, blood sugars more than 200 milligram per deciliter. It is fulfilling in this question because it's already 450 milligram per deciliter. Number 2 is pH of less than 7.3. It is clearly written 7.0 in this question. So definitely it is fulfilling the criteria. And number 3 is ketonemia or ketonuria should be documented, right? Okay. Anyway, first 2 things are given in the question already. So we can say that it's a case of diabetic ketoacidosis. And also, and look at the pH value given in this question. It is 7.0, which is suggestive of severe DKA also. Very important. In the classification guidelines, it's very clearly mentioned pH less than 7.1 is called severe decay. So 7.0 will fit into the category of severe decay. So this is severe decay in the child given in the question. Question is, what should be the next best step in the management? Okay, everything is related to fluids actually, right? And this is purely based on guidelines. First and foremost thing, what is the type of fluid you're going to use in decay management? It is NS. Okay, right? It is normal saline. So this option, last option, having ringer lactate is wrong. That is out. Second option, 20 ml per kg of half normal saline, that is also out. We are not using that fluid. It is only NS which we are using, right? So only two options are left. Is it 10 ml per kg NS over 20 minutes or 20 ml per kg NS over 20 minutes? It is 20 ml per kg NS over 20 minutes only, because 10 ml per kg NS over 20 minutes will be an under correction. That's what you need to remember. Remaining things are all okay only. Previously questions have been based on that also, right? So let us see the full option. 20 ml per kg of NS over 20 minutes. We aim for 10% deficit correction. This also should be kept in mind, because I told you previously that this child is having severe decay. And in severe decay, it is assumed that there is a 10% deficit already occurred in the child. So we should aim for 10% deficit correction by giving 20 ml per kg of NS over 20 minutes. And after that only, you have to give insulin as an infusion. Along with the infusion, you have to add potassium chloride also. See, you may think that in this question, in this particular question, that potassium level is normal only. Okay, 4.8 is very normal, 3.5 to 5.5. Potassium is very normal. You may think, why should I give potassium for this child? What is the answer for that? Once you start insulin infusion, what is going to happen? There will be an intracellular shift of potassium, resulting in decreased levels of serum potassium once you start insulin infusion. So that is why after you start insulin infusion, you should always add potassium in the fluid also. So that is why KCl addition is also justified. So very clear answer for our question is option C, 20 ml per kg NS over 20 minutes, followed by that insulin infusion with the addition of potassium, right? So that is the clear answer for this question. Now moving on to the last question. A child is NS1 antigen positive and presents with fever and warning sign. What is this NS1 antigen positive in a child with fever? It is nothing but dengue fever. Dengue fever. And this child is having warning signs also. I'll elaborate more on that. Then lab findings show hematocrit of 41% and platelet count of 50,000 per microliter. What is the most appropriate next step in the management? Okay, first of all, let me quickly tell you about the warning signs in dengue fever. Okay, very important for exams also. There are multiple warning signs. Number 1 could be abdominal pain or tenderness. Number 2, child is having persistent vomiting. Number 3 is clinical fluid accumulation. Okay. Number 4 is letharginess or irritability, both extremes, irritability or letharginess. And number 5 is mucosal bleeding. And number 6 is liver enlargement more than 2 centimeter. That is included in the guidelines for warning signs. And last one is the lab values. What is that lab value going to be? Increase in the hematocrit. Concurrently, there is a drop in platelet count. Okay, so both should occur together. That is, increasing hematocrit, concurrently there is a decrease in the platelet count also, right? So both of them occurring together. These are all the different warning signs in case of dengue which you need to be aware of. Now let me come back to the question. The question clearly says that this is a dengue with warning sign. And if you look at the 4 options, 3 options are related to fluids only. The first 3 options are related to fluid. The 4th option related to platelet transfusion. First of all, is platelet transfusion routinely documented? The child is having low platelet. I'm asking the question, is it routinely documented? It is not routinely documented. Please keep this point in mind. Platelet transfusion, the guidelines very clearly say that it is only for massive bleeding which are not controlled with packed RBC transfusions. Right. Is it given like that in the question? Not at all, right? Child is having dengue fever with warning sign, but nowhere it is mentioned there's a massive bleeding not corrected with PRBC transfusion. So definitely that option is out. All the remaining 3 options are related to fluid. So let us just quickly see what are the guidelines related to fluids in platelet with dengue. First and foremost thing, the type of fluid which is preferred is always what? Crystalloid or colloid? Yes, of course. Crystalloids are the ones which are preferred in dengue fever, which is either ringer lactate or normal saline. Either one of this can be used. And the amount of fluid you're going to give initially depends on the blood pressure. That is, with hypotension or normal blood pressure. If it is no hypotension, that means normal blood pressure, you will start NS or ringer lactate, anyone, at the rate of, very important, note it, 7 ml per kg per hour. This is the starting infusion rate. After you start the infusion, after 1 hour, you have to see. If the child shows improvement, then we can decrease the infusion rate. If the child is not showing an improvement, we should increase the infusion rate. Very simple, right? On the other hand, if there is documented hypotension, I'll write on the other side. If there is documented hypotension, then you can use NS or ringer lactate again, but at the rate of increased rate. What is that? 10 to 20 ml per kg per hour. This is what you're going to use if there is documented hypotension, right? So that should be kept in mind. Okay, right. Now, let's come back to the question. The question, we clearly ruled out there is no platelet transfusion rule here. Then, it is not mentioned, right? There is hypotension. So let us take, there is no hypotension in this child. If there is no hypotension, obviously it should be NS or RL. But what is the starting infusion? Yes, it is 7 ml per kg per hour only. So what is the clear answer for our question? It is option B, which will be the answer for this particular question, right? So that was the last question of pediatrics related questions in this INI-CET November 2025 exam. So as you can see, majority of the questions were on the expected lines only. There were no major surprises this time in pediatrics part. And if you have learnt all the PYQs very thoroughly, you should have been able to answer most of them. And of course, few questions were analytical questions also, where you apply the knowledge and try to rule out the options also, right? So going forward for the future INI-CET exams also, I expect the similar pattern only, where majority of the questions will be based on the expected topics, but in-depth questions or guideline-based questions are going to be more often asked in the future exam. So with that note, I am ending the session and I wish you all the best for the upcoming exams.